We then come to contact time with the surface of absorption. Picture it this way. I have a drug in, let's say, my small intestine this way. This drug needs to cross into circulation. Now, if the drug spends less time in the small intestine and crosses to the large intestine, then it means that we don't have enough time for the drug to be able to go into circulation. And that may become a problem for us. But then, if the drug spends enough time in the small intestine, then we will have an adequate time for the drug to be able to go into circulation. So imagine a patient with diarrhea who has taken some drugs. The drug is going to move from the small intestine quickly to the large intestine and ends up in the feces. So such a patient, it will be difficult for you to have enough drugs being absorbed because the contact time is short. But if the patient has no diarrhea, then because the drug may be in the small intestine for a longer period, we would expect that all things being equal, if the size is okay, charge is okay, lipophilicity and other factors are okay, then the absorption into circulation should be good enough. So that is how you look at the contact time. So let's assume that the patient takes drug A, and then there is another drug, drug B. And drug B probably speeds up the transit of drug A from the small intestine to the large intestine. It means that drug B is likely to affect negatively the absorption of drug A. But if drug B delays the transit time of A, and A stays in the small intestine for a longer period, then we would expect that the drug A would be absorbed better, as long as all other factors are accounted for. Then presence of food. Sometimes we hear instructions like, take this drug after meals or with food, or take this drug before meals. Now, this is because some drugs are absorbed very well when there is food in the stomach or in the small intestine. And some drugs get to be absorbed less when there is food. So for some of those drugs that the presence of food may affect the absorption negatively, we would normally advise that the patient takes it on empty stomach. Okay. But if the drug is absorbed well in the presence of food, then we would expect that such a drug would be taken either immediately after meals or after maybe just whilst eating, you take the drug. So we say with meals. It is also possible that sometimes a drug may cause irritation in the gastrointestinal tract. So when drugs do that, we may ask that the patient takes the drug with meals. So there, the issue is not so much absorption, but it has to do with the fact that we want to curtail the irritation that the drug would cause to the gastrointestinal mucosa. All right. Now, once we talk about the presence of food, we may also need to look at how this influences blood flow to the site. Okay, because when you deal with presence of food, once someone has eaten, the food needs to be digested. So usually during digestion, the food has to be broken down. The nutrients are supposed to be assimilated into circulation. And so blood flow just some minutes after eating is improved. So all things being equal, ideally, food should have helped with, let's say, absorption. But the problem is that the physical presence of the food can compete against the drug molecules. That is why usually the absorption is not improved But otherwise, blood flow just after eating is enhanced when someone has eaten. Then we talk about disease conditions. There are times that certain disease conditions patients have may influence how well a drug could be absorbed. Let's picture someone with migraine or someone with peripheral neuropathy. Such people tend to have a decreased gastric motility. I repeat, people with migraine or peripheral neuropathy may have a decreased gastric motility. Now, if there is a decreased gastric motility, it means that the movement of food from the stomach to the small intestine, where majority of the drugs would be absorbed, would be slow. And since it will be slow, it means that the absorption would also be slow. So I may give the person a drug to treat the migraine, but absorption is so slow that the drug is not able to work as quickly as I want it, or it may end up, the intensity of action may be a bit less than what we would want. And so if I am addressing migraine, sometimes we may give a drug together with the anti-migraine drug that may speed up the movement of the drug molecule from the stomach to the small intestine. And when that happens, it helps to improve the absorption for us. So those drugs that speed up the movement of the drug from the stomach to the small intestine, we call them prokinetic drugs. And an example is metoclopramide. Metoclopramide, right? So this could be added to the anti-migraine drug to enhance the transit of the drug molecules to the small intestine so that that would improve absorption. Now, the same way, if a disease condition moves drugs too quickly from the stomach to the small intestine and from the small intestine to the large, then that can negatively impair the absorption because you don't have enough contact time. So that can also happen, right? Then we come to presence of other drugs. Sometimes our patients may be on 2 or more drugs, and it happens that they are supposed to take these drugs at the same time, or they take one after the other. Now, sometimes when there are certain drugs in the system, the presence of those drugs may either delay or slow down or reduce the absorption, or they may enhance the absorption. I'll give you 2 illustrations here. Let's assume we have a patient who is anemic, iron deficiency anemia, and we give iron preparation to this patient. Now, iron is absorbed well when it is in an acidic medium. So if I were to take vitamin C, which is known as ascorbic acid, if I were to take vitamin C before taking the iron, it would improve the absorption of the iron. So here, the drug is enhancing the absorption. But if this same iron was taken together with an antacid, the substances in the antacid would form complexes with the iron and delay the absorption of the iron. So you realize that the same drug, iron, with 2 different drugs, the scenario is different. In one situation, the iron is absorbed better. In another situation, the iron is absorbed slowly. We may also look at tetracycline together with an antacid, where the ions in the antacid, like calcium, magnesium, or it could be aluminum, will cause a reduction in the absorption of tetracycline. The reason being that these salts or these ions would form a chelate with the tetracycline. And so the tetracycline isn't absorbed because the size has become huge. It cannot easily cross the membrane, and that would impair its ability to function the way we would have wanted it. Now, to summarize, I'd like to say that we have looked at how absorption is important, how it influences our onset of action, intensity of action, and duration of action. And we've also looked at how there are certain factors that can influence your drug absorption. We've considered issues like physicochemical properties. We've considered the pH of the medium, the routes of drug administration, the blood flow to the site, the surface area, the presence of food, the presence of other drugs. And we've also looked at the fact that certain disease conditions can influence drug absorption. I hope that this simplifies the concept of drug absorption for you. On this note, I would like to say thank you for paying attention to what we have for you today. Don't forget to subscribe to our channel. The link is just on the board. And subscribe, like, comment, share, and turn on the notification so that the next time we share any video, you will get an update. And so we hope to see you again.